resuscitation nurses pulled out of for a number of reasons. First of all, what you really need is an orthopedic surgeon or a surgeon that's willing to go out and backfill their position at the hospital, because you can't not have an orthopedic surgeon at a trauma center. And we have a team of dedicated CRNAs, certified registered nurse anesthetists, that are willing to maintain this practice and go out. We actually learned that resuscitation nurses had no use out there. Plus, you have to backfill, and we didn't like the idea of that. You have to meet the standards of any pre-hospital provider. So you have to have, and all these pictures that I'm showing you are actual Go team footage where they are actually doing an extrication. So you have to do yearly training. You have to maintain all your pre-hospital standards of care. You have to have a commitment that you're going to come in or backfill a position. Safety issues. And then how do you get the Go team to the scene? And then when the patient leaves the scene, how do you get the Go team back? So it takes a tremendous amount, but we've been very helpful most of the time. The only time we're not helpful is when times we get an unusual case and the Go team thinks they should go, but they haven't been asked to come. So we say, unless you're invited to the scene, don't go to the scene. You have no use. How we get them to the scene? In this case, we used our inter-hospital transport team to get them to I-95, because it's only a mile or two away. The Maryland State Police, who are our major pre-hospital transport air team, they will come and pick up our Go team and take them with them if requested. So we do have a complete system in place. When they get to the car, they find out that he is completely trapped, and this is their vehicle, and it just scares me to look at it. It gives me like chest pain to look at it, because look at the intrusion on that driver's side. And they decide that really what he needs, he has been trapped, he's getting cold, and he's frightened, so they intubate and sedate him. They begin transfusing him. We send packed red blood cells out with the Go team. There's talk of sending FFP with them. And now that he's sedated and intubated, the actual field team that's out there can get him out. I'm not sure how, but they get his legs out. And he's transported by the first responders to the shock trauma center. Express Care stayed on the scene, and they brought our trauma team back to us. So we didn't lose a CRNA and an orthopedic surgeon. And Barron comes in, and we begin his resuscitation with Dr. Scalea managing him. Now, he's got potential hypothermia. He's been bleeding in the field. He's going to be a bloody, vicious cycle if we don't get on top of him from a resuscitative point of view. He has a pelvic fracture, and we have to immediately put a pelvic binder on him. Yes, the company makes them pink for us, because we are shock trauma, so they wanted to be able to say shock trauma uses our binder. So we immediately put a binder on Perrin. Then he goes to the angio suite. We want to embolize anything that's bleeding. We don't want him to bleed to death in his retroperitoneal space, so we stop any bleeding from going on. And Barron goes up to the ICU. Do we know who he is? No, he's a doe. Every patient that comes with trauma is a doe. Even if you're awake and alert and oriented. Dr. Cowley started that system back in 1968. When we went to Epic, they wanted our doe system to go away. I think Dr. Scalea's got a stronger personality than Dr. R.A. Cowley. He said, oh no, I'm not going to have somebody bleed out because we can't get blood for them, because we have to wait till he would figure out who they are. So Jess is in the PACU, post-splenectomy. Barron's up in the ICU as a doe. Do we have any identification on either of them? No. I don't know about you, but I don't carry an ID when I'm on I-95 in my person. It's on my purse in the back seat. If you're driving from Fort Polk to New Jersey, you think you're going to be driving with your wallet in your back pocket? Only if you want a nice sciatic pain, right? So we have no idea. Meanwhile, their families are waiting for them to come to New Jersey. They don't arrive in New Jersey. They're both in shock trauma. And parent, for some reason, has his lung, and probably part of it was being in the field so long, being cold, he has a terrible blossoming pulmonary contusion. The only thing that doesn't make sense to me, and they're clear, Perrin was driving and Jess was the passenger, but their injuries are almost flip-flopped. You would think if his chest would be injured on the left, and you'd think it would have been her liver, not her spleen. But those are where they were in the car. We know because of the entrapment. I think because the car was spun around and hit so many times, that I don't think we know the pure mechanism. I think they were struck and hit Jersey walls and were running into 18-wheelers, and that's not the best thing to be running into. So his pulmonary contusion is getting worse. Now, I am showing my age. I actually, in the late 70s and early 80s, we didn't have pulse oximetry. Do you know that? Is anybody old enough to remember that? Yeah, oh good, okay, thank you. There was no pulse oximetry. In the late 70s, early 80s, it was started in the OR, then it made its way out to the NICU. Then we said, well, this would be pretty nifty to have in resuscitation to figure out if people are hypoxic without having to draw blood gas. And then slowly it's become a standard of care. I can actually recall over by 1980, we lost a patient to a pulmonary contusion because he was out on the floor, and by the time he showed signs of hypoxia, it was too late. We couldn't turn him around. We didn't have advanced lung technology then. So he's got a nice blossoming pulmonary contusion. And of course, that's on CAT scan. You can just see how sick that lung is on the right-hand side. Pulmonary contusions haven't changed over time. The chest wall hits an object, all the energy gets transferred to the lung tissue and small airways, and that causes swelling and bleeding. It's actually more common in young people. Why? Because their ribs are softer and will bend. The lung takes the impact. If you're old, your ribs are going to break. They're going to break on the impact. So think of pulmonary contusion. Think of somebody with a nice, young, healthy chest. Your assessment is pretty basic. Is it hurt for them to take a deep breath? Do they have pain? Are they in respiratory distress? Do they have a PO2 with less than 60 on room air? Or do they have bloody sputum? But for the most part, I think we know that by the increasing oxygen needs with the decreasing O2 sat. And our support is 100% supportive. Give them as much O2 as they need, put them on a ventilator, do postural drainage, do chest PT to get the blood out of their airways, suction them frequently. And of course, we are going to have them on pulse ox, you're going to do capnography, you are going to get blood gases. And you want to do some calculated respiratory parameters like a VQ scan, and you want to make sure they're normally volume related. You don't want to fluid overload or under resuscitate them. So now we're in the PACU, and now 24 hours has occurred. She hasn't gone into labor. The little girl's still sleeping. She's got beautiful fetal variability. So we're going to extubate Jess and see how she's doing. What's the first thing Jess wants to know? How's my husband? What husband? They have the same last name. Oh, that's right. We don't know his name. He's been here for 24 hours, and nobody's been able to figure out. Do you think we could go to the cars from the crash scene? You want to try to figure out where all 67 cars were towed off 95? That's going to be a challenge, don't you think? So, in our defense of maintaining a doe, is anybody calling to say they were on 95? No, the parents are in New Jersey. The people down in Fort Polk don't even know he's been in a crash. They know he's going home for the weekend. They're not expecting to hear from them. So in the PACU now, we continue to fetal monitor the baby. And we look for contractions, but she's doing absolutely fine. I show this slide just to tell you that none of you, unless you're fetal monitor certified, don't ever initial a fetal monitor strip, because it is considered the most litigious piece of equipment in healthcare, because for the next 16 years, they can come back and say, that's where the cerebral palsy occurred. That's where the ADHD occurred. That's why this child has learning differences. So keep your hands off of it and be happy that the OB team is there. And I think if you look at this, it just makes you know there's three kind of decelerations. There are accelerations, variable decelerations, and late decelerations. And that's why you're going to have two nurses for at least the first 24 to 36 hours. I think you can clearly justify that. So Perrin's up in the ICU on a ventilator, requiring a tremendous amount of respiratory support. We do finally identify this must be her husband, because she's describing him to us, okay? And so we figure out, we think that's Perrin. We don't know for sure, but we're going to try to get pictures. We're trying to get a hold. She can now tell us where her family is, so we can at least finally ID him and let her know her husband's alive. And he's not paralyzed, by the way. He's moving his legs. He just couldn't feel him because he was so trapped in that vehicle. Pulmonary contusions can trigger a systemic inflammatory response, or SIRS. There's some thought that indomethacin might help the pulmonary contusion. There's no long-term studies done on patients with, if you're looking for an area of research, nobody's studied patients with pulmonary contusions. There is some theory that people that suffer pulmonary contusion later in life, they might have fibrotic changes permanently to their lungs. And I was fascinated when I was reviewing the literature, prepping for this. I think it's an area that needs to be studied. Our oldest son was a preemie, and for a while he was smoking, and I used to say, Andrew, the weakest system in your body is your lungs. You're in a NICU for a week. Look what you're doing to your damaged lungs every time you laid up. I think they became too expensive. That's why he doesn't smoke anymore, but that's okay. That's a good thing. Now, interestingly, I've practiced so long that when we used to get military patients, we would keep them. Why? Because in their 80s, there was no war. And military medicine was civilian medicine. They were doing vasectomies and tonsillectomies. And so our military personnel that came to shock trauma stayed with us. Well, of course, we've been at war so long now that that's no longer true. So as soon as they were both stable, Walter Reed wants the patients there, and that's where they continued their recovery. But it's not quite over yet. At 36 weeks, Jess goes into labor. She is still a patient at Walter Reed, and so is her husband. So while he is having additional surgery, he is in the OR having his pelvis repaired, while she delivers a full-term baby girl. I do have to look at my notes because her name is a little unusual. I think I have one more beautiful picture of her. Yeah. Her name is Nelina Grace, and it means beautiful one from heaven. And I just think that's just such a beautiful name, and she's such a beautiful little girl. Thankfully, if she was a little girl, they're much tougher in utero than little boys. And that's Perrin and her doing well now. We had to call Fort Polk at some point and inform them that he was not going to be going to deploy because he was still in our ICU on the ventilator. He remained in our ICU for a number of days. That's why we weren't letting him go until we could get him extubated. There was no way we were going to transport him vented to Walter Reed. We weren't going to have that go south on us. This was their car. I can't imagine getting him out of that vehicle. So, how have they done? They were transferred to Maryland, where Perrin continued treatment for more than a year of his injuries. Jessica works as a physical therapy assistant in Northern Virginia. And that's Nelania, who's now more than a year old. Nelania Grace, doing well. And I think these two cases from the I-95 crash show you that trauma systems work. You're dedicated here for your education so that you can give the best trauma care possible. It's always my pleasure to be here.